So today's video is going to be about regulation of the heart, basically the heartbeat and the electrical conduction system within the heart. And we'll look at an EKG and work on being able to interpret that. Okay, so let's start with the internal control of the heart. So the heart regulates its own heartbeat. So the initial electrical signal that goes to the heart muscle that tells it it's time to contract, comes from the heart itself. The brain can influence it, but your pacemaker of the heart, what determines that you're going to have a heartbeat or a heart contraction, comes from what's called the sinoatrial node. The sinoatrial node is oftentimes abbreviated as the SA node. It is located in kind of the top of the right atrium. You can see it here on your diagram here. So that's where the electrical impulse that is going to control the heartbeat is going to come from. And it's set at a rhythm usually between 60 and 100 beats per minute. Okay. From that sinoatrial node, the electrical impulses will travel through the heart to get to all of the cells so that you can have a nice, steady contraction of the heart. And so the flow of that electrical impulse is going to go from the sinoatrial node through the AV node, which is the atrioventricular node, to the bundle of His, which is actually pronounced like it has an extra S on it. Okay, the bundle of His, the right and left bundle branches, and then the Purkinje fibers, which are going to come in contact with the actual heart muscle cells. So you can trace it in your diagram over here on the right. So we start here at this sinoatrial node, and then the message is going to pass down to this AV node here. From the AV node, it's going to head down into the bundle of His, which is kind of at the top of the interventricular septum, right? That kind of wall that separates the right and left ventricle. From there, it'll branch into the left and right bundle branches, so headed off to the right and the left ventricles. And from those bundle branches, branch into those individual Purkinje fibers that are going to go to the individual heart cells. And this is all going to happen super duper fast. If you remember looking at heart cells under the microscope, those intercalated discs that were located in that heart tissue that kind of set it apart from the skeletal muscle, those intercalated discs are what are helping spread that message super fast so that all the muscles get it at the same time and we get a nice smooth contraction, not kind of a wonky, wobbly contraction. Okay, as for external control of the heart, these are, I don't know if control is really the right word. Influence might be the better word because, again, they can't generate a heartbeat, but they can influence the heart rate and the strength of the contractions that are happening. So we have the cardiac center, which is located in the medulla. Remember the base of the brainstem there. This is under autonomic control. So this is where I'm processing information from those sympathetics and parasympathetics, right? The sympathetics are going to increase the heart rate, increase the pressure, where the sympathetics would, calm that back down. But this is going to have autonomic control that's going to adjust our heart rate. So it could, like I said, speed the heart rate up, slow the heart rate down. It can affect contraction strength, which can impact blood pressure, as well as impact that stroke volume. Remember, our stroke volume is how much blood the heart is pumping per minute. Okay. In addition to this cardiac center, we have baroreceptors, baro being like a barometer for weather, right? These are pressure receptors. So these are pressure receptors that you find in the atria, in the carotid arteries, which are going to be found in your neck, and in the aortic arch, so measuring that pressure of the blood as soon as it's coming out of that left ventricle. So these baroreceptors are monitoring the pressure in these big major vessels that are headed up to our head, right, headed up to our brain, headed right out of the ventricle, in the return blood flow in the pressure in those atria. These receptors will measure that pressure, send it back to the cardiac center, so then the cardiac center can try to influence the rate and the contraction strength and the stroke volume if it needs to. So in addition to these baroreceptors telling the cardiac center some information, we've got the endocrine system. And remember, the endocrine system is your hormones. And in particular, some hormones that we have that are going to influence the heart would be epinephrine, that norepinephrine, right? So the adrenaline with the sympathetic nervous system, increasing the heart rate. Another one would be thyroxine, which will come from the thyroid gland. All of these are going to help increase heart rate. So again, another symptom or another system that can influence the heart rate. Also, we've got our emotions, and physical activity are going to influence our heart rate. If we're really upset, if we're very scared, physical activity also, both of these can stimulate that sympathetic branch again, therefore, usually increasing heart rate and potentially increasing blood pressure. Okay, so let's look at our electrocardiogram and kind of look at the parts of it and what they mean and what they're telling us. So, our electrocardiogram, which can be abbreviated with an ECG or an EKG. So the electrical cardiogram is giving us the electrical activity of the heart because, again, the heartbeats are controlled by this electrical activity. Okay, they're showing us where the heart is contracting, which would be in the areas where it depolarizes, as well as where the heart is relaxing, which are in those areas where it is repolarizing. And these are the same as when we talked about depolarizing and repolarizing with the nervous system, right? We change our ion concentrations, which affects the electrical charge on either side of the membrane, which can signal these contraction and relaxation phases. When the heart is beating normally in its regular rhythm, that is called sinus rhythm. And we're going to talk about, after this, we're going to talk about some arrhythmias. So sometimes where it's not beating normally. So we can we'll take a look at some of those and see what those are. So looking at our regular electrocardiogram, it should look like this snippet of this one here on the right, and it'll just repeat. Okay, and so first we have what's called the P wave. So this one here is the P wave. And in the P wave, those SA nodes are firing. So this is kind of the start of that electrical conduction system. So the SA nodes are firing, and the atria are contracting. So that's why we see this small little spike here, because the atria here are depolarizing. Right? And when we see a depolarization, that's going to signal that I've got contraction happening. And when we see a repolarization, so when it dips back down, that is going to signal relaxation happening. So the SA nodes are firing during that P wave, the atria is contracting, and we've got depolarization of the atria happening there. So it's a small little wave here because remember, atria don't have a big giant contraction. The next thing that we have here is called the QRS complex. So it takes this whole big spike into consideration together. So at this QRS complex, so this whole area right here, okay, we've got the impulse now is at those Purkinje fibers. And remember, those Purkinje fibers are the ones that are talking to the heart cells themselves. So what's happening here is the ventricles are contracting. That R portion, where we see this big, large depolarization here, okay, that's those ventricles contracting. Okay, so the ventricles depolarized. And then the final part that we have here is this small portion here, this T wave. The T wave looks a lot like the P wave. Okay, and so what's happening in that T wave, okay, I've got ventricles relaxing here. Okay, everybody, the ventricles are also, since they're relaxing there, those ventricles are repolarizing during that T wave. Can't spell. So this is what we should see happening when, like I said, again, when we're in that normal sinus rhythm. So if we're not, we're in what we call an arrhythmia. So we're going to look at some examples of arrhythmias here. We don't need to have them all memorized or anything. We're just kind of looking at some examples and getting a feel of how the ECG could change. Okay, so we are going to want a little bit of vocabulary here. So the first one that we're looking at here is bradycardia. Brady is slow. So basically what this is I've got a very slow heart rate happening here. And so if you'll look at it, I've got my normal P wave, my QRS all looks good and normal, and so does my T wave. The difference here between this and a regular EKG is this chunk in between beats here is much further apart. We can compare it to this one over here, which is the tachycardia. Tachy is fast. So this is a fast heart rate, where again, I'm seeing, you can see the T and the P are kind of mushing together here. And there's very little space here between these QRS complexes. So this person is having a very fast heart rate. Okay, the one down here at the bottom, the PACs, these are premature atrial contractions. So like this one says, the atria is contracting prematurely. Basically, the atria is contracting before the SA node fires off. So you see almost this like extra QRS wave looking here because the atria is contracting too early. And so you see this extra blip instead of the normal space here that we would see between two heartbeats. Okay, the next one you may have heard of on some of your medical shows and stuff, atrial fibrillation. So atrial fibrillation, basically the atria is contracting really, really fast. So the atria is contracting, it's almost like fluttering because it's contracting so fast. It's contracting greater than 350 beats per minute. I mean, it is just boom, 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 boom. Okay, and so basically what we see then is a whole bunch of these little atrial contractions here because it's essentially just constantly contracting. The PVCs are our premature ventricular contractions. And where these are going to help us is when we do that online lab and try to diagnose, when we're looking at some EKGs, it would be helpful to be a little bit familiar with things that look abnormal. Okay, so what's happening with these is that the ventricle is contracting too soon. So that's where my premature ventricular contraction is happening. So the ventricle is contracting too soon. And so I'm getting basically these extra QRS complexes closer to the previous one than I should have. Okay, again, we have another tachycardia. Remember, tachy is fast. So in this case, though, it's ventricular tachycardia. And so the ventricles are what are causing the beat. The SA node is not. So you'll notice there's no P wave here because the SA node really isn't firing. The ventricles are basically just fluttering. And so you see this constant ventricular contraction, which is that much larger depolarization. Okay, so then I have my ventricular fibrillation, similar to that atrial fibrillation. And again, that I'm going greater than 350 beats per minute. Okay, it's essentially just fluttering because it's contracting so fast. This is a problem. This needs to get fixed, right? This is you're going to need like a heart shock situation here usually. Okay, and then the last one I have down here on the bottom is this third-degree heart block. Okay, so basically what's happening is I'm getting some blockage from that SA node as well as the AV node. So my first impulse from the SA node gets delayed. So you can see that getting delayed there. The second one is intermittently blocked. So sometimes it's blocked, sometimes it's not, okay, which is where I get this big repolarization here before I get my contraction because it's kind of slowing everything down. And then the third wave is completely blocked. So I'm not even seeing that one on many of these. Okay, so this is a heart block. Basically, it's going to look upside down. Okay, so some of these arrhythmias could require the use of a defibrillator. So we have these around campus. You've maybe seen them. They're labeled AED, a automatic external defibrillator. Those would be the kind that we would use. Anybody can use them. It'll walk you through the process of using it. It'll tell you exactly where to put everything and what to do. So this automatic external defibrillator, this is what you see when they are shouting clear in your in your medical shows and stuff, and they mean it. You do not want to be touching the patient because they're sending what these will do is they send a very large electric shock through the patient's body. So basically we place the pads on either side of the heart and we send the shock goes through the heart. And what they will actually do is this will actually stop the heart. So whatever arrhythmia is happening in the heart, whatever the fibrillation, the whatever's going on in the heart, what the AED does is the defibrillator will send such a big electric shock, it will stop the heart, which then the ideal situation now is that the heart will then start on its own and it will start on its normal rhythm. It basically like cancels out the problem that's going on, the fibrillation that's going on. So when they shout in the movie, in the movies and the medical shows, when they shout clear, and then they give them the shock, and then they pick it up and they wait and they look at the machine to see if the heart will start beating again normally on its own. So that's what it was doing. They sent such a big electrical shock, it actually totally stopped the heart so that the heart can then pick back up on. So the SA node almost resetting the electrical system of the heart. So then the SA node can pick back up on its normal rhythm. Okay, so we'll be working with some EKG pictures. We'll be tracing this pathway, and this is the wrap up of your heart information for your heart test.